So I want to start by calling up the audience poll. Do we have that ready? The two polls for this? Yes. So the consumer survey results were 53% of people think I really wasted money, and the other 38% think I probably wasted money. And let's see what you guys thought. Can we switch on to the poll? 22% of you were kind of in the same ballpark as me, so that's great. You're much more in line with me than the general consumer was. Can we get the? There we go. There it is. That's it. Those are my chromosomes. What does that tell you? Well, I had two likely significant variants. I'm a carrier for both of these. I don't have either of these. If I had either hereditary hemochromatosis or trimethylaminoria, we'd know by now. The same goes for these, which were of unknown clinical significance, but were suspicious. And then there's about 500 of these, which are variants of unknown significance that may or may not mean anything. And that's basically the result. I mean, I could dig into each of those for you, which I don't really quite feel like doing. But that's basically what we get shown this. So I decided to do this. I've been covering this stuff for a long time. And I always said that I wasn't going to try this out, and my excuse was that I thought healthy people shouldn't, that there probably wasn't any utility in doing this for a healthy person in their mid-30s who you don't have any reason to sequence. And I always thought that this would be a difficult thing to learn. So I went to see Robert Green because he's the guy who's done all the studies that showed that when you tell people they have variants that up their risk of Alzheimer's, that they actually handle it quite fine. He's been an absolute expert in this field, I should note. He's not just some doctor I walked in off the street. And you compared this to giving a student an echocardiogram, that was the reason to do this, that you find out about what the process is by doing it. And that is kind of true. I do feel like I've learned something from this. But it's hard, and it's hard to know what any of these genes mean right now. I mean, that's kind of the big difficulty. I mean, I look at Alzheimer's. There's a variant of unknown significance in my presenilin gene. I have ApoE heterozygous, but I know that my grandfather had Alzheimer's. And the question in my family has always been, did he develop Alzheimer's because we all have some ticking time bomb inside us? Or was it he'd also had several blows to the head, which we know from those studies of football players that we've all been watching. He was on a ship in the Merchant Marine, a steam pipe came out and hit him on the head and knocked him out for half a day, supposedly. I wasn't there. But the genetic information doesn't help me with that at all. There's no predictive value there beyond what I've learned myself. And so, Bob, you've gone through this, aside from helping me do this, you've gone through the same experience yourself.
Yeah.
I mean, so where are we in terms of thinking about healthy people going through this process and learning?
Well, thanks for coming to me, Matt. And this is a huge, huge question in the medical world, much bigger than anyone in this arena may make of it, because you are all, by definition, forward-thinking, proactive, information-seeking people who believe in data and believe in information and believe in the power to inform yourselves and make a difference in your lives. So you got to keep that in mind, as well as the history of medical genetics. The history of medical genetics, where we discovered Mendelian variants first, horrible things like Huntington disease. And the trauma that medical geneticists would sit there with when they had to tell you that you've got the Huntington mutation and your life as you know it is going to be over at a much earlier age. So this shaped the entire mentality of a medical specialty, of medical genetics.
Well, I want to state really up front, I think this was a valuable thing for me, cost aside. But this doesn't always work out happily. I did have a commenter on a story once who told me that she had gone to Myriad Genetics to get her BRCA gene tested, and it had come up positive, but then she went to 23andMe. And, well, the 23andMe test was negative, so she figured that other test was wrong, so she didn't do anything. Now, it turns out even what we did here really isn't enough to look at a BRCA gene and figure out risk. You really need to have detailed sequence of the entire gene. So there is a risk of people getting this information and misunderstanding or misusing it and being hurt.
And if you're a clinician, you just have to sit across from one or two families over a stretch of years and have one of those misunderstandings result in a serious outcome or a devastated patient or a loss of a child before you become extremely tentative about what information could mean. So I've been on the cutting edge of delivering genetic information and trying to measure the harm of it. And for most people like yourself and like this audience who seek it out, we're finding that there is very little harm. But I just want people to know where that mentality is coming from. It's not only paternalistic medicine, there is a lot of that. It's not only sort of a ossified medical establishment, though there's certainly a lot of that. It's partly the emotional experience of being a clinician when you have witnessed people experience traumatic events in front of you.
But then we have this opposite problem, which is you get traumatic news. I mean, your example is great. I think that was actually from 23andMe, but you got sequenced, or is it
I got sequenced several times. I did the pilot from the exome from 23andMe. I've done it twice with Illumina, and gotten great data each time. Nothing has been claimed that was out of proportion, but the variants that were reported out to me as suspicious gave me pause. For example, in one of the first exomes that I got, the Treacher-Collins gene, which is a terrible disfiguring illness that you're born with.
Now, it's one of these things. We can tell he doesn't have Treacher-Collins right now, looking at him. This isn't like a...
Yeah, but if I were a pregnant, I mean, we're thinking about the future. If I were a pregnant mother, and somehow you'd extracted my baby's fetal DNA out of my bloodstream, and you told me that there was a variant that was leaning pathogenic in Treacher-Collins syndrome, that would be devastating possibility for that mother. Probably could be disproved with an ultrasound, but that's the kind of thing that gives people pause when they're talking about probabilistic genetic information.
Does anyone want to ask a question, or should we keep chatting?
I will say, while people are thinking of a question, that this is what we've been studying now for over 14 years. We started by asking the question, is it damaging? Is it harmful to disclose ApoE for Alzheimer's disease? And then progressed to asking the same question about the panel of direct-to-consumer genetic testing using 2 companies, and we're now asking that question about whole genome sequencing in adults and in newborns.
One thing that really struck me here, though, that I didn't understand before, is that one of the reasons it's not harmful now is because there's not that much you can tell me about predictive risk. And what we tell people is actually about things where you actually have a gene for something or other where it really means something. But what happens when the genes start to really mean something? And what happens when we really understand ApoE and presenilin and whatever other risk markers we're going to find for Alzheimer's?
Actually, we can do better than that, Matt, because about 6 people in this audience are probably carrying a pathogenic variant in a known cancer predisposition gene or cardiac predisposition gene right now. That's real meaningful data. It's only about 1.5% to 2% of you, but
But you still have questions of penetrance. You've got all these get-out-of-jail cards.
You do.
Those get-out-of-jail cards are going to go away. We're going to understand penetrance, which is whether or not that gene causes you to have whatever trait you think it's going to cause to have. So in some way, these experiments that we're doing on healthy people aren't what we're actually going to have when you have a genome that's actually predictive?
Well, I think the newest frontier is sequencing healthy people. Actually, the question about sequencing sick people has been asked and answered. It is part and parcel of cancers we've been hearing, and it's now becoming part and parcel of any disease where there is a suspect genetic mutation. So we're seeing families all the time with mysterious illnesses. No doctor could figure me out, and they're coming in. I've got 2 other relatives who have a similar syndrome. They're coming in, getting sequenced, and we're finding the answer to those.
And that's happened really fast. The Rick Lifton patient in Turkey, which didn't have a name, which was actually before Nick Volker, but that was 3 years ago, 2 years ago?
We've got 6 cases we figured out in the last 3 months, and that's happening every day now.
So I'm still working really hard to work through this question that's been bothering me for years, is should people who be allowed to get access to this data as a matter of course? And I kind of thought yesterday that I was coming around to the, as I have a bunch of times over this, coming around to the idea that yes, they should. I've never quite gotten to know they shouldn't. But I still am not sure. I'm not sure if, I guess I kind of feel that maybe you should let people do what I just did, but I'm not sure that there's a great reason to do it. Paul? Oh, we have one up here.
Yeah, Matthew, just a simple question. How was your DNA analyzed, and how much did it cost? And then a question for Dr. Green. I read an article recently that said about 8% of the people in the world really have a rare disease that's genetically based, and that by 2020, we actually will know all the sequences associated with that. And if that's true, how can we not kind of institute massive screening of children as they're born, so that they, at least in the future, would have that knowledge? Thank you.
So it was done by Illumina as part of their Understand Your Genome program, which is a program for doing exactly this kind of giving a med student or journalist the equivalent of an EKG for educational reasons. The costs, which are not all in, they're going to be costs both from his hospital and from Illumina, but say single-digit thousands of dollars. And I don't remember the coverage or any of that offhand. I went through it when I got it. It was pretty good, but there are all the caveats with that kind of genome sequencing. I mean, I don't know anything about my copy number variants. I don't know anything structural. There certainly wasn't any RNA-seq or anything like that done. You could probably learn a lot more. And Illumina right now has a policy that makes it somewhat restrictive to get BAM files. So I don't actually have that because they feel that analyzing the BAM file is basically part of the sequencing, and that they can't just give you that as part of a CLIA lab. That has to be done in a research setting.
So Illumina does this with a physician's order through a CAP and CLIA certified laboratory. So they're doing it within the medical care system. There's other research projects that are offering people, healthy people, or as I like to say, ostensibly healthy people, because everybody's got something, their genomes through a more research arena. But to respond to your comment, I think you're exactly right. There's, who knows, 10%, 5%, 20%. There is a substantial number of people in the aggregate who have rare diseases that have genetic, and by genetic in this case, I think we mean fairly highly penetrant or Mendelian causation. And we are learning at a rapid rate more and more about that. So I think the narrative of screening with sequencing is a pretty hard narrative to resist. I think what we do have to understand, though, is these kinds of VUSs and uncertain findings, what are the implications in terms of downstream costs, in terms of iatrogenic problems? If everybody, there was one audience member here who told me about long QT running in their family. If I screen you all and I find a long QT running in your family, and your physician overreacts and puts a pacemaker into you, that's a potentially unnecessary surgery. So there's a lot of downstream costs and potential harms to this as well that we haven't figured out till we solve the penetration.
I mean, if we couldn't deal with PSA without cutting into people unnecessarily, I'm a little worried about what we do with I mean, you saw, I got maybe 4 or 5 really useful pieces of information and a bunch of stuff that we'd have to do a huge amount of work to work through it all. That's
now,
tough.
What's useful for him at this point in his life might be different if you're about to have a baby.
Well, I picked a time when my wife and I aren't planning any more kids. My kids are healthy. I'm not sick in any way. I picked a time when this information is actually of lowest utility.
But now let me ask you, if you were about to have a child, would finding all those carrier states influence you to have your spouse tested?
I don't know. And I might not have, I mean, the decision I made at that time was not to do anything like that.
See, I think that's the low-hanging fruit here. People talk about pharmacogenomics as if it's the low-hanging fruit. I actually think...
There was a drug screening test. It was really, it means I can go on Plavix instead of Effient if I want. That was basically it.
I think the low-hanging fruit's going to be preconception screening. I mean, why should I leave it to chance if my partner is carrying the same recessive trait in the same gene as I, leave it to chance that we would end up together and then have a 1 in 4 chance of having a devastated baby. That's something I could test for and do something about right away.
You're right, and if someone came to me with that proposition exactly, it probably would have convinced me. Paul, or we have one up here first?
Dr. Green or Matt, are any of you aware of, even anecdotally, where an ostensibly healthy person has one of these tests and changes their life based on it? They quit their job, they move to the beach, what have you?
No.
Well, yes, I'm aware of many such anecdotes. There's actually is a support group of people who learned that they were E4 positive, for example.
Oh, okay, yeah.
And they report doing certain things differently. This is under the entire rubric of personal utility. We talk about, you know, analytic validity, clinical validity, and clinical utility, and there's a 4th category, personal utility, that is talked about a lot.
This is, you can decide that you know your risk of having a bad old age is higher, so you're not going to wait to.
It won't surprise you because it's entirely rational, but we were the first ones to demonstrate that if you learned you were E4 positive, you were more likely to purchase long-term care insurance. Believe me, that came as a real shock to the insurance industry. They were quite shocked about that.
Paul?
Yeah, so I actually want to share something with you, Matt. It turns out I did 23andMe back when you could get health information from
right.
You can at this point, but hopefully will in the future. And I have a great deal of sort of ambivalence, as you do, about whether somebody should be getting this information based upon what happened with me. And I'll preface this by saying I'm a physician. And so what happened was I turned out to be heterozygous for the minor hemochromatosis gene in the 23andMe test, which comes with a 1% risk of developing hemochromatosis over your lifetime because it's an accumulation of iron in your cells. And I told my physician about it, a really good physician, well-known physician in Boston, and he said, gee, let's test your ferritin, see where you are. I said, okay, fine. Tested my ferritin. Normal ferritin level goes up to 400 in the test I took. Mine was 393. And I came back and he said, normal, you know, ignore it. But in fact, right on the edge, really at the very top and so I have no idea what to do with this. Should I be getting, you know, should I be giving blood as much as possible to reduce my ferritin levels? Should I just forget about it? I have no idea.
Or get tested again a few times and see if you ever go far out of normal.
I'm a physician. I can't imagine somebody who, you know, has a college, you know, liberal arts education in something unrelated to biology who gets this. I have no idea what they're going to do.
Or you don't have to. I mean, they could have a high school education.
High school education.
With no biology. I mean, no, it's
right.
really.
I disagree. I think that as soon as somebody gets that finding, they're going to do the best they can to learn what to do with that information. They may not learn about it with your sophistication, but they're going to go and they're going to ask their doctor, what does this mean? And they're going to ask pointed questions. And that's the kind of empowerment I think that would be the good side of self-disclosure and self-examination.
Well, I mean, I have to say, one thing I've learned in the past 15 years is patient advocates, man. They know their stuff like nobody else. I mean, nobody digs deep, especially, I mean, the people, I mean, especially parents of children with disorders. I mean, they really, sometimes they learn things that maybe you do find people who have ideas that aren't true, but there are also a lot of people who really figure things out. I don't know that it makes sense to keep, and this becomes a philosophical question, are you willing to not help the people who would really be helped by the information?
Well, when you get into sharing,
in order to avoid harming the ones who'd be hurt.
We've got examples, Matt, of these parent groups, like you're saying, that will actually sit there around a rare disease, compare genomic variants, and in some cases have documented to come up with the answer that scientists never got those rare cases together. That it was all the advocacy group. It's quite remarkable.
And we have another question up there. John?
So Bob, you mentioned you've been sequenced 3 times, right? What's the concordance between the calls? And Matt, have you thought about what the level of confidence is in each one of those calls?
Can I answer that first? I'm not that confident.
Well, John, you know Zach's phrase about the incidentalome, and I've got a catchphrase too, and my catchphrase is the incidentalome is shrinking. And by that I mean that as we get better and better at characterizing what is really a meaningful pathogenic variant, the number of things in any person's given genome that you actually have to worry about is shrinking. When I first got my first one, I had about 3 times the number of things you have, Matt. But what's happening is that laboratories are getting better and better. So I think the concordance is different now because people are getting better primarily at variant classification.
The last few weeks, there have been some nice papers showing that targeted panels, for example, do a much better job than exome sequencing.
Absolutely.
Or whole genome sequencing, exome sequencing, which is far better than whole genome sequencing. And so I think one of the challenges we face is interpreting this data in a domain where there's still a good deal of uncertainty, not only about what the variants mean, but in our confidence of what the variants truly are. If we took Matthew's BAM files and ran them through a different variant collar, we might get a slightly different
really want to do.
Totally agree.
Right? And so, we all talk about this as if we know what's coming out of these assays, but there's still room, I think, for improvement in the assays themselves. So
that's right.
I love your experiment, but...
Yeah. Well, I totally agree, and that's why when the American College of Medical Genetics asked me to lead a working group on incidental findings, we initially struggled with this almost to the point of drowning ourselves in the question of uncertainty. So we decided to recommend a very small number of genes, 56 genes out of your 20,000. And only if you have a clear-cut pathogenic variant in those 56 genes and you're getting sequenced for another reason, did we recommend that additional information get returned to you. Now, you guys might find that incredibly conservative, but the genomics world reacted with a great deal of uproar about even recommending that much disclosure about your own genome.
I mean, I want to point out, we're running out of time, but this actually does tie into one of the big themes we've had today, which is that more data isn't always better. What John just said, that going and doing a whole genome may not be as good as doing an exome in a lot of cases, and it's just looking everywhere. So we do want to be figuring out, with all this stuff, what the right data is, and I think that's a lot of the... Harlan?
I think one of the issues is going to be for us to understand the unintended consequences and what the weight is. We know from medical sociology studies that if you label someone as hypertensive, they'll have higher absentee rates than people who have the same blood pressure but don't get the label. And so we need to understand, on one hand, what the burden is of carrying around information that may never come to manifest. The other thing is that we have this sort of tension, I think, between a deterministic view of the world and a stochastic view of the world, a probabilistic view of the world. There are some cancers that are clearly, or diseases that are clearly deterministic. Point mutation here produces this disease, but most of our conditions are much more complex than that in regard interactions of a lot of different things, epigenetics, outside the genome. And so we're putting people in wristbands. We can't say for sure what's going to happen to you. We can only say that you're either at higher or lower risk for a particular condition. how people process that information, because we're not saying this is what's going to happen to you, we're just saying there may be a little greater chance of this happening to you, and how that gets worked out in terms of, so what happens downstream, and how do we manage it, and what are the impact on individuals? I mean, all of these things I think are going to be very important as that information starts to spread.
Well, and that's exactly why we're running something called the MedSeq project, which is a randomized trial of using whole genome sequencing in the practice of medicine and then following those people downstream, and just got funded in addition for the BabySeq project to do the same thing for newborns.
I will say psychologically, this was a lot easier having a pretty stochastic view of the world. We're done. That's it, John. Sorry. Okay. But I'd love to talk to you later. Thanks a lot, everyone. This was fun. We're out of time.